You can be thin, you can have normal BMI, you can look healthy in the mirror, and you can still have fatty liver disease, sometimes the more dangerous form of it. This catches patients off guard every single week in my clinic. Someone walks in, BMI of only 22, eats relatively well, exercises a few times a week, and their ultrasound shows the liver loaded with fat. They're confused, their primary care is also confused, and honestly, the field of medicine took a long time to take this seriously. I'm a board certified gastroenterologist with over 20 years of experience. In the next few minutes, I'm going to explain why thin people get fatty liver, why it's often worse than fatty liver in people with obesity or overweight, and what to do about it, especially if you're South Asian, Indian, East Asian, or Hispanic, and because the risk for you is even genuinely higher. The medical name for this is lean MASLD, MASLD. It used to be called lean NAFLD. It refers to fatty liver disease in people with a normal or near normal body weight. The cutoff most studies use is a BMI under 25 or under 23 for Asian populations. Roughly 10 to 20% of people with fatty liver disease have lean MASLD. That's millions of patients globally. And here is the part that should grab your attention. Multiple studies now suggest that lean MASLD patients have similar or even worse long-term outcomes than overweight fatty liver patients. Higher rates of progression to fibrosis, higher cardiovascular mortality. The disease may actually be more aggressive in this population, not less. Why does it even happen? Why can a thin person have liver full of fat? The answer comes down to one concept. It's not how much fat you have on your body, it's where the fat sits and how your metabolism handles it. Body fat comes in two main types. Subcutaneous fat, which sits under your skin, that's the visible, pinchable kind, and visceral fat, which sits deep inside your abdomen, wrapped around your organs. You cannot see visceral fat from outside. A person with a flat stomach can have a lot of it. A person with a soft belly can have a very little. Visceral fat is metabolically aggressive. It releases inflammatory signals. It dumps free fatty acids directly into the portal vein, which goes straight into the liver. The liver gets flooded with fat it can't process fast enough, and it starts storing it inside its own cells. That's fatty liver. A thin person with a high proportion of visceral fat will have a fatty liver. A larger person with mostly subcutaneous fat may not. The number on the scale doesn't tell you which type you have. There is a name for this body composition pattern, which is called TOFI, thin outside, fat inside, and the populations where TOFI shows up most are often South Asian, East Asian, or Hispanic. There is strong evidence that people of these backgrounds genetically tend to store fat viscerally rather than subcutaneously. Even at low BMIs, even at low body weights, the fat goes to the wrong place. This is why South Asians develop type 2 diabetes, fatty liver, and heart disease at body weights where white European populations would still be considered metabolically healthy. The risk threshold is lower. The body composition is different. The genetics are real. So what causes lean MASLD beyond ethnicity? A few things. Number one, dietary fructose. Fructose is processed almost entirely by the liver, and high intake, especially from sugary drinks, juices, and ultra-processed foods, drives liver fat directly, regardless of total calories or weight. A thin person who drinks 2 sodas a day is putting more stress on their liver than a heavier person who drinks water. Number two is sedentary lifestyle even at a normal weight. Skeletal muscle is your largest insulin sensitive organ. If you don't have much muscle, your insulin sensitivity drops and fat starts moving into the liver. This is why thin sedentary people who never exercise but stay slim due to genetics, are surprisingly common in my clinic with fatty liver. Number three is genetic variants. The PNPLA3 gene variant, especially common in Hispanic populations, predisposes people to fatty liver independent of genetics. If your father or your aunt had liver disease and you're thin, you may have inherited the predisposition. Number four is rapid weight loss in the past followed by regain. All these diet trends can actually drive fat into the liver even if your current weight looks fine. And the number five is poor sleep and high cortisol. Chronic stress and sleep deprivation are independent drivers of visceral fat accumulation. A thin person who sleeps 4 hours a night and lives on cortisol can absolutely have a fatty liver. Here is how I screen for lean MASLD in my clinic. I look at waist circumference, not BMI. For South Asian men, a waist over 35 inches is concerning. For South Asian women, over 31 inches. For non-South Asian population, the cutoffs are 40 and 35. A thin person with a thicker waist than their frame suggests has visceral adiposity unless proven otherwise. I look at the metabolic labs. Fasting glucose, hemoglobin A1C, and fasting insulin, triglycerides, HDL. If any of these are off in a thin person, the liver is almost certainly involved. I check liver enzymes, AST, ALT, GGT, and I use the lower threshold. ALT over 30 in a man, over 19 in women is concerning, even though the lab report calls it normal. And if there is any suspicion, I order an abdominal ultrasound. It's cheap, non-invasive, and it answers the question directly. So, what do you do if you're thin and you find out you have fatty liver? The treatment is mostly the same as for any fatty liver patient, but with a different emphasis. You're not trying to lose a lot of weight here. There is not much to lose anyway. You're trying to change your body composition. That means resistance training. Build muscle, even a little, dramatically improves insulin sensitivity and reduces visceral fat. This is the single most important intervention for lean fatty liver patients. It means cutting fructose hard, no juice, no soda, minimal added sugar. Read labels. It means improving sleep. Aim for 7 hours minimum. Untreated sleep apnea is a major driver in lean populations and frequently missed. And it means managing stress because chronic cortisol is feeding the visceral fat depot. If you're South Asian or East Asian, I would add one more thing. Take this seriously even if your doctor doesn't. Your risk profile is real. The Western medical threshold for screening were built on Western populations. You may need to advocate for tests your primary care doesn't routinely order. Here is the takeaway. Fatty liver is not a disease of overweight people. It's a disease of metabolic dysfunction, and metabolic dysfunction can show up in any body size. If you're thin and tired, thin and bloated, thin with a thicker waist than your frame suggests, thin with a family history of diabetes or liver disease, you're not exempt. The mirror is not the diagnostic tool. The labs and imaging are. If this video helped you, please subscribe. I make evidence-based videos every week on gut and liver health. See you in the next one. Thank you.